Get started. Good morning, everyone. Thank you for joining us again. I'm going to make sure I'm going to enable the chat so you can speak with everybody. Good morning. Good morning. Happy Monday. I would love to hear which webinar you have has really resonated with you so far. So if there's if you would like to share in the chat which webinar has been your favorite so far, that'd be awesome. We love hearing feedback from you. Like I said, we will send out a survey on Friday, the 21st, to just get more feedback so we can continue to develop and improve our programming. And you'll also be able to indicate if you'd like a certificate of completion in that survey. Ooh, the last one we had Dr. Langer, Dr. Ben Shalom. Good morning from Jacksonville. Ooh, you love the virtual ORs. I did too. I like that's I think my favorite part is being able to see our surgeons in action. And I feel really lucky because I get to actually watch some surgeries sometimes, but I don't really get to see like what they're seeing in the exoscope. So it was really nice for me to be able to watch that too. Good morning from Brazil. Thank you for joining us. Good morning. Good morning. So we're going to get started in about 5 minutes. Before we begin, I just wanted to go over a few housekeeping things. So first and foremost, we want to thank you all for being here and joining us for our second week of the BrainTurn webinar. Oh, yay. So glad to hear you enjoyed the Women in Neurosurgery discussion with Dr. Ronit Gilad and Soraya Motovala. Thank you so much for joining us for that, all in the virtual ORs. Love that. Just a few housekeeping things. We want to make sure we're keeping the chat professional and respectful. So please, no cross talking, no like saying like, oh, what's your favorite color to somebody, or inappropriate language in the chat. We'd like to keep it professional. If it does get out of hand, we will disable the chat. So don't ruin it for the rest of the BrainTurn series. We also encourage you, if you have any questions, our next speaker is Salem Najjar. Najjar, sorry, and he's a fourth-year medical student, and he's going to be giving a great talk today about neuroanatomy. If you have any questions for him, please post that in the Q&A so that we can record your questions, and then any questions that we don't answer. Is it okay if we share your email, Salim? Is that okay? Yes. All right. Perfect. Oh, I know you're on mute. So we'll make sure to share Salim's email in here as well as Dr. D'Amico's email. He will be speaking at 11 a.m. So you guys can email us with any questions. And then finally, I'm just going to share some links in here. We love to stay in touch with you. So I'm going to share my screen just so you can see this little slide. You can take a screenshot of this, or I will post the links in the chat, but here are our social media channels that you can follow us on. We're on LinkedIn, we're on Instagram, we're on Threads, we're on TikTok, we're also on Twitter. So be sure to follow us so that we can stay in touch and we can share updates with you about different educational opportunities that are going on within the department. We're also, we have a Facebook group for the BrainTurns. We'll post the link in the chat. And there's also a Slack channel that you can join where you can continue to stay in touch and chat with your BrainTurns cohorts. So is there a schedule for this week? Yes, I will be sure to post the link to the schedule in the chat as well. I'll stop sharing my screen. Stop it. Or how do I stop it? Oh, here we go. All right, I stopped it. All right, let's make sure we have those links in the chat for you guys. And we will get started in 2 minutes. All right. Let's see. All right, here's the link to join Copy. Yes, Dr. Rogers is actually going to be speaking tomorrow. So tomorrow morning, he was scheduled for both today and tomorrow. So he will be speaking tomorrow morning at 9:00 a.m. So definitely want to stay tuned for that. It's Dr. Sean Rogers is a pediatric neurosurgeon at Cohen's Children's Hospital. We're really grateful to have him. If you missed his first talk, it is on the YouTube channel. And I will post the link to the YouTube channel in the chat. So that you can watch the webinar or rewatch it if you thought it was fascinating and would love to give it a second viewing. All right, and then here's the Facebook group. Copy. And then finally, here is the link to the schedule. So you can see the schedule for the rest of the week. All right, trying to think if there's any other links I need to share. Oh, t-shirts, yes. I'm like, there's another link I have to share. If you guys would like to purchase a commemorative t-shirt, you can go to the website www.bonfire.com/BRAINterns -summer 2023 -t-shirt / we are selling the shirts. They are selling for $28.99. We actually don't profit off of these. What we actually use the profits for is funding our free educational programming. It's not free on our end, but we want to keep it as accessible as possible. So if you purchase one of those t-shirts, you're going to be supporting future BRAINterns and their continuing medical education. All right. So without further ado, I'm going to pass off the spotlight to Salem Najjar. Salem is a fourth-year medical student at the Zucker School of Medicine with Hofstra and Northwell Health. He has been focusing on neurosurgery and is actually going to be applying to residency this year. And I know he's going to match with an amazing program. I can feel it. So we're really lucky to have him, and we're excited to for him to share more neuroanatomy with us this time, not so much spine, more cranial and brain anatomy. So without further ado, I'm going to pass up the spotlight to Salem. Words.
Thank you so much for that very warm introduction. Thank you guys again for all joining the webinar. It's such a pleasure to see you guys and work with you guys. I've done this webinar for the past couple of years, and you guys truly make the webinars much better with the participation and the good questions. And so today I'm going to share my screen. And here we go. And I think we are good to go. Awesome. Yes. Okay, great. So before we start, why don't you guys tell me about where you guys are joining in from? I'm just monitoring the chat over here. Puerto Rico, Latvia, Romania. Wow. Great turnout. New York. Great. Okay. And are you guys in high school? Are you in college, medical school? High school. Great. College, 8th grade. Wow. Awesome. Okay, great. Well, we have a lot of good things in store for you guys today. We're going to go over a lot of interesting stuff, and we have some great clinical cases we're going to go through. And you guys can just, shout out questions in the chat or answer questions in the chat, and we'll go ahead and get started. Great. Okay. So we're going to talk about the brain. And the first thing we want to look at is what protects the brain, what encases the brain, right? So just to start, we're going to look at, we have the skull and we have the bones of the cranium, right? So there's going to be 8 cranial bones. We have the sphenoid, the ethmoid, the frontal, we have 2 parietal, 2 temporal, and 1 occipital. And you can see that we have the cranial sutures here, and these sort of help separate different parts of the skull. And, these sort of form from when you're an infant to now, and sort of just provides rigid joints in the skull. Great. Okay. So the next thing let's talk about continuing forward with this, is the skull base. So now we're looking from top down. On the left picture, we're going to be looking at the top going down. And you can see here, that we have 3 different fossas or fossae for the cranial base. And it's divided into the anterior, the middle, and the posterior fossa. And from there, you can see the different divisions of the skull that we were just talking about before, with the bones highlighted in the colors below. And then on the right, we're going to look at the skull base. More specifically, the foramens. The foramens are very important because the foramens are going to be where things travel through. So those things are going to be neurovasculature. We're going to see arteries, we're going to see nerves. And so really highlighting a few here, right? We're going to see the foramen rotundum. This is where an important artery called the middle meningeal artery is going to traverse through. We also can see through the internal acoustic meatus that the facial nerve as well as the vestibulocochlear nerve are going to traverse through those, through that foramen. And then we also have the jugular foramen, which is where a very important nerve, the vagus nerve, is going to pass through. And then we see at the bottom, the largest foramen is the foramen magnum. Additionally, I should mention also the jugular foramen. If you guys have ever heard of the jugular artery, or the jugular vein, that's where you're going to see the jugular vein pass through. Oh, somebody asked, when did you start reaching out to surgeons for shadowing and research opportunities? Do you recommend anything specific to connect other than cold emailing? Honestly, cold emailing has always been what's worked for me. Try to link up with somebody at your department. I reached out during my first year of medical school to sort of get into the OR and get research opportunities, and that's been really beneficial. My home program has been very nice to me, and you know, they've showed me so much and taught me so much along the way, and I'm very grateful to them for that. And it's, you know, further developed my interest in neurosurgery, and it's been a really great time. Great. Okay, so continuing back. So we talked about these foramen in the skull base. Great. So now let's go on to the meninges. The meninges are very important because they help cushion the brain, they protect the brain. They're, you know, this next layer below the skull, right? And we're going to have multiple layers of these meningeal layers. We have the dura, the arachnoid matter, the subarachnoid space, and the pia matter. And, you know, you can see on the left here that everything is sort of stacked on top of each other. And there's going to be these very important potential spaces in between these layers of the meninges. And so you can see here that on this picture on the right, we have, it's almost like a stack of blocks, right? So it helps, you know, illustrate these potential spaces, right? You have the scalp, you have the skull, and then you're going to have the dura. The dura is separated into 2 different sort of layers. You have the periosteal dura layer. This is like a tougher layer. This is continuous with the periosteum of the skull. And then you're going to have the meningeal dura layer, which is a little softer, provides more cushioning. And then between that dura and the arachnoid is going to be the subdural space. And then the arachnoid matter is going to be the next layer. Then from the arachnoid to the pia, there's going to be this other space called the subarachnoid space. And then below that is going to be the pia that sort of encases over the cerebrum. And so these spaces are very important because fluid can go into these spaces and cause pathologies. And those pathologies can be something like a subarachnoid hemorrhage, and that will be in that subarachnoid space. You got the subdural hematoma, which is going to be below the dura. You could also have an epidural hematoma, which is above the dura, between the dura and the skull. So those are important spaces that you have to keep in mind, especially when it comes down to diagnosing and looking at imaging. Great. So let's move on to the next slide. And the next slide, we're going to be looking at just the brain itself. Looking at the brain itself, you can see there's, you know, the lobes I'm sure you guys are familiar with. You have the frontal lobe, the parietal lobe, temporal lobe, occipital lobe, and those are basically what we need to be looking at from this picture. You also can just see the general anatomy and how everything is related to each other. You can see that the brainstem, you know, based on what Kosh spoke to you guys last week, I'm assuming, you know, the brainstem is going to be almost like this highway between the brain and the spinal cord. You see the cerebellum over here. You see some of the basal ganglia over here. And you see these other important subdivisions that we're going to talk about a little bit further on the next slide. And yeah, any questions about this division of the brain? from this view. This is a sagittal view. You're looking at half of the brain. You're looking at the right side of the brain. Any questions here? And I see your question about lessons that you wish you learned earlier on in med school. I'm going to address that later at the end when we do questions. Any questions here? Okay, great. So let's move on to the next slide. Looking at the next slide. Now we're looking at the functional parts of the brain, right? So we see, so can anybody tell me what this area right here is? What this is called? Central sulcus, great, perfect, exactly. And the central sulcus is a very important anatomical landmark, both on imaging as well as, you know, in the OR, just anatomically, or in the lab if you're just examining brain specimens. And so the central sulcus is a very important landmark. It helps divide the primary motor cortex located in this precentral gyrus from the primary sensory cortex located in this postcentral gyrus. And so that's going to be sort of your division of motor versus sensory. Another thing we'd like to talk about, it's not labeled here, but what is this called? Do you guys know what this area is called? This little division? Lateral sulcus, perfect. Lateral sulcus. And what does the lateral sulcus separate? Temporal lobe and frontal, exactly, perfect. That's another important landmark for identifying different parts of the brain. And that's very important, especially when you're looking at like actual anatomical specimens in the lab or in the OR. And you can see also, you know, we're going to talk more about the actual lobes here very specifically. You know, the frontal lobe is where you're going to have your judgment. It's going to be for coordinating voluntary movement. This is like executive functioning in the frontal lobe. Then you also have the parietal lobe. The parietal lobe is for sensory. It helps sort of interpret the sensory stimuli from different parts of your body and make sense of it. You have the temporal lobe, which is helpful also for speech and in understanding speech and memory. And then you have your occipital lobe, which is going to be helpful for processing visual stimuli and making sense of the things you're seeing in the environment. So 80% of the brain is comprised of the cerebral cortex. We also have, you know, this thin sheet of tissue covering it. That's the cortex itself. Other parts that we want to talk about is we talked about the motor cortex. So for motor cortex and sensory, right? Which one is a descending track and which one is an ascending track? Great. Somebody said motor's ascending and sensory is ascending. Perfect. Okay, great. You guys are on top of it. Perfect. And for motor, does motor innervation occur ipsilaterally or contralaterally? For example, if I had the right side of my body paralyzed, what side of the brain would you say is implicated? Left. Perfect. Perfect. It's contralateral. Perfect. Okay. For sensory, is it contralateral or ipsilateral? If I had numbness on the right side of my body, what part of the brain would you say is implicated if you were to try to localize that lesion? Contralateral. Yes, exactly. And we're going to go over that a little bit more. So yeah, somebody said depends on the lesion. Fine. It depends on the location of the lesion. That's perfectly fine. But generally you want to think that it's going to be contralateral because it's going to decusate at different areas. And we're going to see exactly how that works. Decusate is just a fancy word for saying, you know, crosses over. Okay, great. So we hit everything here. The next thing, oh, sorry. Last thing I want to talk about. Have you guys ever heard of Broca's aphasia? Okay, so you guys are familiar. So it's an inability to articulate and make speech, right? Whereas Wernicke's is you have a hard time understanding speech. So the words you say are actual words, but it's not really responding in a logical, coherent manner. Great. So let's go on to the homunculus. I don't know if you guys have ever seen this picture. It's kind of a weird looking picture, but this is very helpful for understanding how different parts of the brain map to different functions within the body. And on the left, you see the sensory portion of the homunculus as well as the motor portion of the homunculus. And you can see how it's distributed across the brain that we were talking about before with the central sulcus, right? And so you can see there are some similarities between both. You have the face on both of these lateral sides. You have the feet in towards the medial side. And so you can see that, you know, there's going to be all these different projections. We're going to see in another figure later. There's different projections from these different sort of parts of the homunculus that end up coming together into, you know, forming the corona radiata and coming through into the internal capsule and passing down, at least on the motor side. Great. Awesome. Okay. So the next thing we want to talk about is cerebral vasculature. This is very important. This is for localizing lesions. This is important for just understanding how the brain receives its oxygen supply and its nutrients. So the brain receives 1/6 of the total cardiac output from the heart, and it uses 1/5 of the oxygen stores. It can't store nutrients either. So it's very important that it receives a consistent, constant supply of blood in order to, you know, function at its peak capacity. And so you can see that, you know, looking down here at the circle of Willis, this is a very important phenomena. This is where you're going to see the vertebral arteries come up. It forms the basilar artery, and then it feeds into the posterior communicating arteries. From the posterior communicating arteries, you reach the area of the MCA, aka the middle cerebral artery, where you're going to have the internal artery coming off medially, and you have the MCA coming off laterally. And then from there, you're going to have the anterior cerebral artery, and that's going to supply the front part of the brain as well as the medial inside portion of the brain. The middle cerebral artery is going to be supplying this lateral surface of the brain, and you're going to have the posterior cerebral artery supplying the occipital or posterior portion of the brain. So that's very important for understanding, you know, if you were to see a lesion in a patient, where that lesion is going to be and what sort of artery could be implicated. And, you know, when you do cerebral angiograms or CTAs, you can see that, you know, you could have this complete circle of Willis picture that we're seeing here. This is not exactly always the case. It happens about 50% of the time, as you can see, but there are anatomical variations. So if you're doing a CTA or cerebral angiogram and you don't see every single part of the circle of Willis lighting up, it doesn't necessarily mean it's a stroke. There could just be anatomical variation. Great. Awesome. Okay, so we were saying before we were going to talk about the motor pathway. So we have the primary motor cortex we were seeing before on the previous images. They come down, they go into the internal capsule, they pass down, they go through the brainstem. As we were talking about before, the brainstem almost serves as like this highway between the brain and the spinal cord. And so it passes down and it decussates at the medulla, and then goes down to the spinal cord, and then it goes on to whatever other muscle that it needs to go innervate. So that's how motor pathway works, and that's why it's going to be contralateral, right? Because you're going to have, in this case, it's going to be the left side of the brain coming down, decussates, and crosses over to the right side of the body. Great. Will we get access to the slides later on? Yes. I'm sure that I'm going to be sending over the slides after, and they'll be posted.
Yes, we'll be sure to share the slides to the Slack channel, and then Quinn can also post it on the Facebook group for y'all.
Perfect, great, thank you so much. I'll make sure to do that right after. Great. So that is the motor pathway. How are we doing on time? Great. Okay, so sensory pathways. Sensory pathway, we were sort of talking before earlier, you know, it starts from wherever the sensory stimulus is coming from. We said this is an ascending tract, right? So we're going to have, there's two different sensory pathways that we're going to talk about here. I believe we talked about this. Oh, what does UMN and LMN stand for? Sorry, we'll go back 1 second. UMN, this is an upper motor neuron, and this is a lower motor neuron. So sorry, back to the sensory pathways. So we have two different pathways we're going to talk about. I'm sure we've talked about this either in previous years or maybe even last week with the spine. But you have the dorsal column medial lemniscus pathway. This is where you're going to get proprioception, innervation coming through, and it's going to decussate at the medulla, and it's going to come up and synapse back in the primary sensory cortex. And then for the spinal thalamic tract, you're going to have sort of temperature or pain stimuli. It's going to cross at the level of the spinal cord and then travel up to synapse in the thalamus and then up to the primary somatosensory cortex. So that's why, sort of driving this point home is why you get this contralateral innervation. Great. So going on to the brainstem, we see a ventral, dorsal, and lateral aspect of the brainstem, right? And we can see that the brainstem is sort of divided into 3 different parts. You have the midbrain, you have the pons, and the medulla. You're going to have 2 cranial nerve nuclei in the midbrain. You're going to have 4 nuclei in the pons and 4 in the medulla. Are lesions to the brainstem, do they present ipsilaterally or contralaterally? Ipsilaterally, yep, exactly. Ipsilaterally. Perfect. And the pons is known to be the biggest part of the brainstem. And you can see there's very important nuclei in the pons. For example, the cranial nerve 7 is here. And the medulla is going to be very important for not only just the cranial nerve nuclei, it also serves as, like we were talking about before, you can see decussations for the motor and the sensory pathways in that area. It also is important for important life-sustaining functions like breathing. That's a very important part of the brainstem. And radiologically, when you're looking at neuroimaging and you're looking at the midbrain, what does the midbrain look like? What's like a good way to describe it? That way, when you're looking at imaging, you know what level of the brain you're at and what level of the brainstem you're at. Any ideas? It looks like sort of like Mickey Mouse. That's what it really looks like. It has like Mickey Mouse ears when you're looking in the axial view from superior to inferior. That's just one way you can help figure out where you're at with the brainstem. Great, okay. So let's move on. The cerebellum. Cerebellum only accounts for 10% of the brain volume, but it actually accounts for more than half of the brain's neurons. What does the cerebellum help do for the body? Balance, great. Movement, coordination of movement, walking, gait, perfect. Yeah, perfect. Coordination, perfect. And so fine-tuning voluntary movements, great. And so you can see here we have the vermis, which is more medial or midline. They're going to have these nodes, lobes on the side, and it's really divided into 3 lobes. You have the anterior, posterior, and flocculonodular nodes. That's how this cerebellum is divided. And you're looking from this way, you're looking inferior to superior. So this is the bottom of the cerebellum. Great. And lesions to the cerebellum, do those occur ipsilaterally or contralaterally? So yes, ipsilaterally. So believe it or not, lesions to the cerebellum present ipsilaterally. And so sometimes you see with especially pediatric, the pediatric patient population, you're going to see something when one of the most common tumors you can see in the pediatric population is going to be something called a pilocytic astrocytoma. And that will occur at around this region and sort of compress or interfere with the cerebellum. And it can present with ipsilateral deficits with coordination, balance, walking, fine motor movement. And so that's sort of how you can help localize that lesion further. Great. Okay. And so let's dive into some clinical cases. You guys could just, fill your answers in the chat or fill ideas you have in the chat, ask questions as needed, and we're going to go ahead and get started. So the first case, our patient is a 22-year-old male. He's an aspiring MMA fighter. While practicing, his opponent strikes him in the side of the head with a vicious kick. The patient initially loses consciousness, but then wakes up and appears fine. His trainer brings him into the emergency department and a CT scan is done. The patient is now somnolent and the results are shown of the CT on the right. What is going on here? Somnolent means sort of like dazed, sort of deteriorating mental status. He's like essentially sleepy. So what is going on here? Concussion, subdural, What else you guys got? Epidural hematoma, subdural, traumatic brain injury. Okay, so let's do this. So this is going to be an epidural hematoma. Why? What on this scan is sort of pointing you towards epidural hematoma? The shape of the lesion. And the shape of the lesion is, how would you describe the shape of the lesion? Does it look like it's confined? Convex? Okay, great. Does it look like it's confined, or do you think it kind of just goes where it wants? Superficial to where the dura is, perfect, exactly, because it's epidural, above the dura, between the skull and the dura. It's pushing inwards, okay? What do you guys think about its like confinement? Does this look confined to you? Yes, okay, great, yes, it is confined. Why? Let's talk about this. So, looking at an epidural hematoma, you can see it's between the dura and the skull, right? You have a skull fracture here. So this person got kicked in the side of the head and it led to this epidural hematoma. And you can see that it does not cross suture lines. The sutures that we saw in the first slide does not cross those lines. And that's one way of knowing this is an epidural hematoma. It kind of looks like a lemon or a lens or a football. There's a lot of different ways to describe it, but it has this confinement. Whereas a subdural hematoma is going to pass through the suture lines. It sort of just cases the whole area here in the below the dura in the subdural space between the dura and the arachnoid. So that's how that's going to work. The next thing let's talk about, let's go back a slide. We said that this is an epidural hematoma. What in the vignette sort of makes you think that this is an epidural hematoma, and specifically in terms of the patient's presentation? This wakes up and appears fine. Do you guys know what that's called? Lucid interval, exactly, lucid interval. So, initially the patient lost consciousness. He woke up and, he looked fine, but then he deteriorated again. That's what we call lucid interval. And I don't know if you guys picked up the hint in the vignette. What is the artery? What artery is the culprit of this epidural hematoma? MMA, exactly, the middle meningeal artery. You guys picked up on it exactly. And do you guys remember which foramen the MMA passes through? Yes, foramen spinosum, exactly. Perfect, foramen spinosum. Great. So the next thing let's talk about. We talked about clinically what an epidural hematoma looks like. Let's talk about what a subdural hematoma looks like. Subdural hematoma, some risk factors. You're going to have a patient that's, has AFib and is on blood thinners or just on aspirin or all sorts of different blood thinners. So that also puts you in a position for excessive bleeding. You can have a patient who drinks alcohol that also can put you at a risk for bleeding. You also have an older patient because the brain, as you get older, has an issue where these bridging veins get put in this precarious position. And so with trauma to an older individual, the bridging veins can get sheared and it can lead to this subdural hematoma. Does that make sense? You guys with me on the epidural versus subdural distinction? Great. Okay, awesome. Okay, great. So next case, let's see where we're at. Okay, next case. 37-year-old female. She's presenting to the office with double vision, drooping of the right eye, and the findings shown in the picture for the past week. She also reports a longstanding history of migraines and hypertension. CT is done. Before we talk about what happens if it's untreated, what's going on here? What sort of issues do you see happening? Firstly, let's talk about the eye findings. We said we have double vision, drooping of the right eye, and this sort of picture. Is it damage to the extraocular muscles? Maybe. How about like the next step further? There is pupil dilation here, yes. Facial nerve, no. Close. Third nerve palsy, exactly. This is exactly something affecting the ocular motor nerve. Perfect. So this is cranial nerve 3. This is this characteristic down and out feature of the eye that you'll see with the cranial nerve issue or cranial nerve 3 issue. So this has been happening for the past week. She also mentions she has a long-standing history of migraines and hypertension. Hypertension is definitely a risk factor for the issue that we're going to be talking about in just a second. And the migraines, they could be migraines, they could just be from the actual lesion itself. Let's look at the image itself now, right? What do you guys see here? Do you guys see anything affecting any sort of abnormal findings in this image here? Calcification, maybe. You're not wrong, because calcification usually shows up white, but something else. Aneurysm, exactly. So let's look. This is the aneurysm right here. And remember, we were talking about the location of different parts of the circle of Willis. So we're going to look at this a little bit further. So looking at this further, remember the posterior communicating artery in the circle of Willis? You can see that there's an aneurysm here. Sorry, it's a little small, but this is the best image I could find. You have the posterior communicating artery of the aneurysm, and then you have the cranial nerve 3. So you can see the aneurysm is pushing on cranial nerve 3 and compressing it, which is leading to those ocular findings that we were just looking at in the previous slide. Now, the next question was, if left untreated, what can this progress to? What do you guys think? Subarachnoid hemorrhage. Perfect. You guys are right on it. And this is what you'd see, this characteristic star appearance for a subarachnoid hemorrhage. And you can see that just sort of reviewing the different types of brain hemorrhages that we were talking about, right? We talked about the epidural hematoma, doesn't cross suture lines. Subdural hematoma does cross suture lines. And you have the subarachnoid hemorrhage, which is below the arachnoid matter. And then you also have intracerebral hemorrhages as well, which you can see with strokes. Talking further about the circle of Willis and these aneurysms, right? The anterior communicating artery has the highest rate of aneurysms at 40%. PCOM is going to be at 20. And that's basically the two different sort of spaces that you'll see these aneurysms located at, but ACOM being more likely than the PCOM. Next thing we want to talk about is, somebody asked before about the optic chiasm. The optic chiasm, you can see, is here. It sort of helps send visual stimuli from the different parts of the eye to the occipital cortex for it to be processed. But a little bit further, a little bit more anterior to this, if we had an aneurysm in the ACOM, what cranial nerve do you think would be affected? Optic, exactly. So you could see like some issues with vision in one of the eyes, depending on what side it's going on. Great, perfect, awesome. Okay, so case 3, 65-year-old male, history of 30-pack year smoking and diabetes, presents the ED upon waking up this morning with weakness in the lower half of the right side of his face. Additionally, he's unable to move his right upper and lower extremities. He has hyperreflexia and a Babinski sign, and sensation is intact. CT is done and it's shown on the right. So let's break this down. So let's do what we were doing earlier with localizing our lesion, right? So his right upper and lower extremities are impaired, or he has hemiparesis on the right. What side of the brain would you say is being affected? Great, perfect. Left. The left side is being affected. Okay. He has hyperreflexia, which you see with upper motor neuron lesions, and he has a Babinski sign. Do you guys know what the Babinski sign is? So yes, it's going to be it's a upwards plantar reflex. When you do a little bit of like sharp stimulation, usually use like the bottom of your reflex hammer and you rub it down on the sole of the patient's foot, and you'll see their foot goes upwards, and that's going to be indicative of a Babinski sign. And that's going to be indicative of upper motor neuron lesions. Now, we also see the right side of his face is being affected. It's specifically the lower half of his face, right? So these are sort of pointing you towards what diagnosis? Stroke, yes. Now let's talk about exactly where the stroke is. Do you guys think this is cortical or subcortical? Cortical meaning in, the actual, the cortex of the brain, cerebral cortex, or do you think this is like in a basal ganglia region? Subcortical. Why do you think it's subcortical? Okay, so subcortical. So we saw before with the homunculus, there's this very large distribution of different parts of the cerebrum that coordinate functions for different parts of the body. For the cortical lesion to happen to cause this profound deficit, both upper and lower extremities and his face, this would have to be a massive, massive stroke. Whereas when you see in the image, this little arrow here, this does not appear to be a large infarct, right? And so this is said to be a lacunar stroke or a pure motor stroke, which is a type of lacunar infarct. This is a stroke of the internal capsule, and the internal capsule is right here. You can see the homunculus that we were talking about, right? Forms down corona radiata into the internal capsule, and then it goes down into the rest of the body. And you can see that this is an infarct of the lenticular striate artery. This is an artery that's commonly affected by hypertension. And so this is one of the first arteries you can see an infarct in if you have hypertension. You can see here that you're having this thickening of the artery itself with atherosclerosis. And on the right, you can see that this is a supranuclear lesion. This is why only the lower part of the face was affected, right? You can see that up here, it's coming down and it's innervating the lower part of the face. But you see that it's also receiving, the upper part of the face is receiving innervation from both sides of the facial nerve, from both sides. So it's bilateral innervation from the facial nerve on the upper part of the head and the forehead region, whereas for the lower part, it's just ipsilateral innervation from the facial nerve, right? And that's going to be a very important distinction for figuring out if something is called essential versus a peripheral facial nerve palsy. And somebody said Bell's palsy. That's very interesting. We're going to talk about that at some point later. And so that's basically what's happening here. We have a stroke of the internal capsule. It's a pure motor stroke. That's why we did not see on the previous slide, we saw no sensory abnormalities. Great. So let's go to the next one. Patient is a 24-year-old female. She's presenting to the ED with facial weakness. Her mother's concerned she's having a stroke and rushed her to the ED. The patient's mother reveals that she had just returned from summer camp and was bit by a tick and subsequently developed the rash shown. This is the rash shown. Patient also reports feeling tired, having muscle aches, and feeling like she had the flu for the past week. Before we worry about rushing to the CT, what is going on here? What is this rash? Lyme disease. Lyme disease, perfect. You have this sort of target sign rash. Great. Why don't you guys tell me what you guys are seeing in the facial findings for the patient? Very concerning for the mother, I would understand that. Bottom of the face is drooping, okay. One side is affected. Okay. How about the eyebrows? You guys notice anything with the eyebrows? One side's higher than the other, right? So you have a right-sided droop. And the eyelids themselves, anything there, guys? Droop in the lower eyelid, okay. And the eye is red itself too, right? Right, okay. So this patient looks to be having Lyme disease, had Lyme disease, and now she has these facial features. The eye is red, probably from the inability to blink, at the correct speed because of this paralysis. And you have the facial droop, you have the eyelid droop, you have the eyebrow droop, that whole thing. So should she be rushed for a CT to rule out stroke? Somebody said no. Okay, so you guys are saying no. And what is going on here? What is the phenomenon that we're experiencing here? Bell's palsy, great, perfect. You guys are right on it, great. And so we saw this picture last time, right? For a supranuclear lesion, right? You're going to get bilateral innervation for the upper part of the forehead, right? Whereas the lower part of the face, you get unilateral innervation from the facial nerve. That's for a supranuclear lesion. For a peripheral lesion, you're going to see that both parts of the facial nerve are being affected, both the top and the bottom of the face. That's why we're getting this. And you can see Bell's palsy with other conditions like varicella, other different inflammatory or infectious etiologies for Bell's palsy. Great. That's a very important point about the upper versus lower facial features. So case five. Case five, patient is a 61-year-old male. He's presenting with deteriorating memory and mobility for the past 2 to 3 years. His wife also reports numerous episodes of incontinence, and the MRI is shown. What do you guys think is going on? What's happening here? What is this? Hydrocephalus. Okay, and what is this part of the brain called? What do we refer to this as? Yes, big ventricles. Yes, ventricles. Lateral ventricles are enlarged. Perfect. Exactly. That's exactly what's happening. You guys are right on this. So what's happening here is we have hydrocephalus. If you can see the normal and hydrocephalus, you can see the lateral ventricles are enlarged relative to the normal. And so you can see that, you know, with the ventricular system of the brain, this is where we're going to get CSF circulation. And so CSF is going to be generated from the choroid plexus. It goes, and this is in the lateral ventricle, and then it passes through into the third ventricle, and then down through via the foramen Monroe. And then it's going to go into the fourth ventricle versus the cerebral aqueduct. And then that's going to empty into the subarachnoid space. You can see it sort of going around the brain here and down into the spine and spinal cord. And this sort of the CSF helps form like a cushion for the brain as well. And that's basically how the CSF works within the ventricular system of the brain. A triad that you should remember, you know, a good mnemonic for this is going to be wet, wacky, wobbly, wet. So wacky, weird, dementia, wobbly, walking, wide gait. So that's the gait instability of the memory issues. And then wet and water, it's going to be urinary incontinence. The patient had unexplained episodes of urinary incontinence. So that's what's happening with this patient. Any questions so far? Great. Okay, great. So let's move on. So our next case is going to be a 45-year-old man with a history of HIV, presents to the ED with a 5-day history of progressively worsening headache, fever, and altered mental status. His family reports he has been increasingly lethargic and disoriented with intermittent confusion and difficulty speaking. The patient also complains of a stiff neck, photophobia, and generalized malaise. MRI and LP are performed. So here's the MRI. You can see these lesions over here. And the CSF study, the appearance is clear and colorless. Opening pressure is elevated. Cell count is increased. White blood cells with predominantly lymphocytes. Protein is elevated. Glucose is decreased, and gram stain is negative. So people are saying meningitis. Perfect. Yes, we are talking about meningitis, which is inflammation of the meninges, which is what we saw on the previous slide of the meninges, right? On like one of the first few slides, right? And you can see there's these characteristic soap bubble lesions. So we're thinking that there's something going on here. The patient has HIV. What do you guys think is going on here? Specifically with HIV. Immunosuppressed, his immune system failed. Yes, immunocompromised, exactly. So opportunistic infections, right? Somebody said opportunistic fungal infection. What made you guys say opportunistic fungal infection? How about the CSF studies? What do you guys notice? Do you guys notice anything here? Anything specifically? Decreased glucose. Okay, gram stain is negative. Great. Gram stain is negative, so we know there's probably not a bacterial origin to this, right? We have decreased glucose. We have elevated protein and elevated opening pressure, and we see lymphocytes, right? So we eliminated a bacterial cause because, or at least mostly, because our gram stain was negative, right? So do you guys think this is fungal or viral? Those are our two other options. Okay, you guys are saying viral. I'm going to say that it's fungal, and let's talk about this. So to figure out how, when we're looking at the CSF, studying CSF is very important. It's a good way to process the information that we're getting, right? So we said for bacterial, you're going to have low glucose, and for fungal, you're going to have low glucose. So our patient had low glucose, right? You're going to have high protein, high protein. For bacteria, you're going to see neutrophils, and for fungal, you're going to see lymphocytes. We saw lymphocytes, right? But you can see lymphocytes with viral as well. And the opening pressure for all of them is going to be high. So our main clues right now are we have low glucose and we have lymphocytes. So low glucose, we're looking at bacterial versus fungal. We said our gram stain was negative and we have lymphocytes, so no PMNs. We have lymphocytes. This is going to clue us in that this is fungal. This is specifically cryptococcal meningitis. And what are we seeing here? This is a stain. This is an India ink stain for a fungal or yeast sort of organisms, right? India ink stain. Cryptococcal meningitis. Cryptococcus is one of the only yeasts that have a capsule. So it's an encapsulated yeast. And so you can see it has this sort of halo appearance on the India ink staining. That's very characteristic. This is pathognomonic for cryptococcal meningitis. And so people were talking about opportunistic infections. They were talking about AIDS-defining illnesses. These are some of the AIDS-defining illnesses that we sort of on our differential here, right? And we saw cryptococcal here. There's other ones like pneumocystis jirovecii. You have CMV. You have toxoplasma. I think somebody said toxoplasma before. Eventually, if things get really bad with the CD4 counts, meaning how many T cells they have, and sort of other sort of comorbidities, you can result with the central nervous system lymphoma in the brain. And so those are some sort of things that we can keep our eyes on with AIDS-defining illnesses. And this is the CSF study is very important. So just to reiterate, you want to look at the glucose. The glucose is going to be very important for helping to narrow out between specifically viral versus bacterial or fungal, right? And then you want to look at the types of cells that we're looking at, and we have PMNs versus lymphocytes. So those are good ways to sort of distinguish between the different causes of meningitis when you're looking at an LP. Great. And we have about 10 minutes. So I want to do our last case, and then I want to leave 5 minutes for questions. So patient is a 48-year-old male, no past medical history, being brought to the psychiatrist's office by his wife due to changes in behavior over the past few months. She reports that her husband has been more aggressive and developed a short temper. This is a stark contrast from his usual behavior. His wife describes him as kind, quiet, and patient. Review systems is notable for daily headaches beginning each morning for the past 6 months. To rule out intracranial pathology and MRI's order, we're going to see the MRI on the next slide, but I want you guys to generate a differential diagnosis. What do you guys think is going on here? Okay, tumor in the prefrontal cortex, great. What makes you guys think tumor, and what makes you guys think specifically the prefrontal cortex? Sort of break that down for me. Daily headaches, great. Gradual buildup, yep. Personality changes point to the frontal cortex, perfect, great, great, great. So, okay, so what kind of tumor do you guys think this is, if you have to say? Just guess, there's, GBM, perfect, right on the dot. So GBM, we actually see here a characteristic butterfly glioma appearance where it's sort of crossing on both sides, right? This is a T1 post contrast. You can see that the tumor is being enhanced by contrast, doesn't have this uniform appearance. It's homogeneous, it's cystic, it looks kind of nasty. And you can see at the bottom, this is necrotic. What kind of necrosis do you see in the brain? What is the name of the necrosis you see in the brain? What type of necrosis? Liquefactive, exactly. Perfect. So when this is done doing the process of necrosis, this is going to end up just becoming a hole. And so you can see this is like a non-uniformly enhancing homogeneous cystic necrotic lesion on MRI. This is an axial T1 post-con. This is a coronal T1 post-con showing the lesion from both angles. And there's different ways we can attack this, right? There's you can do resections, but then there's also these other therapies like laser interstitial thermal therapy, aka LIT. This is thermal ablation, where they put a catheter down and they thermally ablate the tissue itself. You can do stereotactic injections where you can do like targeted chemotherapeutic therapy to that lesion. You can implant a reservoir that can deliver CAR T cell therapy. You could do intra-arterial delivery with antibodies and immunotherapies that can attack the GBM. And sort of shout out to Lenox Hill. Lenox Hill is the first cohort of clinical sites to treat GBM with this new thing called Y90. It's yttrium-90. This is a radioactive element that emits beta rays to destroy cancer cells. And it's currently indicated for hepatocellular carcinoma in the liver, but trials are ongoing to treat GBM. And so you can see here that you have these little resins, these little beads that are filled with this Y90. It's carried through the bloodstream. They sort of do it through an intra-arterial, maybe through the femoral artery, and sort of goes up from there. And it's carried through the bloodstream and delivers the Y90 to the tumor. It goes into the small vessels that are feeding the tumor, because tumors, especially nasty tumors like GBM, they love influencing their microenvironment, right? They try to get all the blood supply they can to maintain themselves, and it kills everything else around it. And so you can get these beads into those microvasculature that's supplying the tumor, and it can help kill the tumor with the Y90. So that's a very interesting, really cool trial that they're doing at Lenox Hill. And the GBMs are very nasty. The 5-year survival rate for patients is only about 6.9%, and the average length of survival for GBM patients is about 8 months. So it's very important that we try to find ways to attack GBMs and rid people of this nasty tumor, and get people back to their functioning life beforehand. And so with that, I thank you guys so much. Any questions? Thank you guys so much. You guys were great, answered awesome questions, asked awesome questions, and it was really a pleasure to be here working with you guys. I love doing this for the past few years. And I will just sort of leave it open to you guys for a little Q&A. You can ask about questions related to med school. You can ask questions related to the topics we covered.
Awesome. It looks like we have a couple questions here in the Q&A. Are there rare versions of the circle of Willis that are pathological?
There could be, but just sort of going through the circle of Willis that we were looking at, doesn't have to be pathological, but there are different variations that I'm not entirely sure but there could be different variations that lead to pathology. Other things that we want to talk about here were somebody asked earlier, are there any unspoken rules or lessons you wish you had learned early on? I don't know necessarily about unspoken rules or lessons. I just know early on, it's very important to figure out what works best for you for studying, at least for med school, what works for you for studying, figuring out how to be the most efficient you can while studying, because you want to make sure you spend enough time in the content to understand it, but you also want to make sure that you're moving fast enough, because what people describe med school as sometimes, and it's kind of funny, is trying to drink water through a straw and the water's coming out of a fire hydrant. So, there's too much to take in at one time. You have to make sure you're doing it the right way. And so finding the resources that work best for you, whether it's reading, whether it's videos, whether it's flashcards, practice questions, there's different ways to approach it. Everyone has their own methodology. And so sort of just making sure you work on that at the beginning part of med school will set you up for success later on in med school. And just working hard, get yourself in the hospital, get yourself exposed to the teams you want to work with potentially in the future. Those are great things you can do. Get involved with research if you're trying to do something interesting, or just trying to do some high level stuff. Get involved with research early. That's definitely very helpful. Other questions that I see here are, what was your best study technique in med school, and how do you overcome overcome giving up when times got hard? I mean, best study technique for me was sort of a combination of videos, flashcards, practice questions, and reading articles related to the pathologies that I was trying to understand. And honestly, what's also great is when you're in med school, you have access to all these wonderful clinicians and doctors and surgeons that you can use them as sort of like a knowledge bank, or you can ask them questions. They can help break things down for you and understand things. I mean, everybody asks for help, everyone gets help, you know, understanding things, even like the CSF. I remember when I was learning about CSF studies, I was on the floors and they were explaining to me how to go to break it down and be able to diagnose a patient based on CSF. And, you know, I sort of just did that with you guys as well. How did you overcome giving up when times got hard? That, you know, just remind yourself why you're here. You know, it's sometimes during the preclinical years, you get a little disheartened because you're tired of sitting in the classroom, you're tired of reading, you're tired of doing practice questions. But then you get back into the clinical floors and you're helping patients and you're learning and you're applying what you know. And it reminds you like, wow, I can't, like, this is exactly why I'm here. So just remind yourself of those times when times get tough. Oh, for epidural versus subdural hematoma, is there a difference in the progression of symptoms like fatigue or ultimate? Great, this is a great question. Epidural hematomas, we said we have that lucid interval, it's very acute, everything happens quickly. Subdural hematomas are more insidious. This can progress over time, right? So for example, it could be like an elderly man, he's walking outside, it's winter, he slips on the ice, he falls backward and hits his head, and you know, he seems fine, everything's okay, and then he starts progressively deteriorating, and that's going to really clue you in for a subdural hematoma, just, you know, clinically. Then you go in and do your confirmatory tests, like you do CT or MRI, and then you look and you see how the blood is passing over the suture lines. There you go. That's what's going to clue you into subdural hematoma. And got a few more minutes here.
What sparked your interest in neurosciences and inspired you to pursue a career in neurosurgery?
Yeah, so I've actually been interested in neurosciences from an early age. I just always found the brain and the spine fascinating. I liked learning how, you know, different complicated phenomena lead to how we function on a daily basis, and how it's such a young field and we're learning so much more. There's so much more room for technology improvements and all these new diagnoses that we're learning about. It's really just very interesting to me. And that was confirmed more when I was on the floors with, you know, the neurology team and the neurosurgery team, doing research with the neurosurgery team, and, you know, those sort of, and being in the OR and seeing this anatomy in real life was just such an opportunity and a privilege. It just really further developed my interest in, you know, my home department was really helpful in guiding that interest for me and showing me all these awesome experiences that I'm very grateful for.
Yeah. Oh, that makes me so happy to hear. I think we are run just about at time for Salim's presentation. I put Salim's email in the chat. I'm going to post it again. It's snajjar1@pride.hofstra.edu. If you have any more questions for him, you can shoot him an email. And then Salim said he would share the slides with Quinn and myself, so we'll make sure that you guys can access the presentation on the Slack channel as well as Facebook. Oh, I love that. Loved your case studies. They really got me hooked. Thank you. So I'm so grateful that this was an inspiring session. I learned a lot myself, and I just want to thank you again, Salim, for taking the time to speak with our BRAINterns yet again. It's been such a wonderful opportunity for us to have you a part of the program, and we just want to thank you for your time and for sharing all of this incredible information.
And thank you so much for having me. It's always a pleasure and an opportunity. And thank you guys to the students. It's a wonderful session. Thank you guys again.
Of course. And so BRAINterns, I'm going to end this session so we can just have a clean recording. We're going to finish off today with a virtual OR with Dr. D'Amico. So we'll see you guys in a few. Thank you so much. Thanks again, Salim. Nice to meet you.
Nice to meet you as well.
Take care.